the traumatic tear. Yeah, traumatic tear of the labrum and the supraspinatus tear. So where the in younger population in shoulder there is a lot of instability cases, and older population there is a lot of degenerative pain and arthritis.
Okay.
Wait, इसको leave कर दूं?
Yes, I'm with you, sir.
I'm shifting to my laptop. Just yes. Yeah, Dr. Abu?
Yes, sir. Yes, I'm with you.
Yeah. Okay. I was just changing from my mobile to the laptop because there was some issue in the network under my
Okay.
mobile. Yeah.
Okay, sir.
So advances in the joint replacement is like robot, computer navigation, artificial intelligence, and AI. These
Okay.
are the main advances in the joint replacement. And same we do in the same sports injury surgeries like robotic or the navigated arthroscopic ACL reconstruction. So
Okay.
before I am going towards the advances, we'll talk basic about things which Varun told me, that how you decide then when to take a call to go for the joint replacement or to go to the any expert specialist which can do the like natural joint again once it is damaged or having the sports injury.
Okay.
Yeah. So by simple getting most of the orthopedic problem you can solve by getting the first investigation, that is the X-ray.
Oh, yes.
So once you get the X-ray, then this will give a clear idea about the present alignment and degeneration and the space between the joint. That give fair idea that how much significant arthritis patient is having. And then clinical symptoms, like patient having problem in the walking and climbing stairs up and down and getting in and out from the car, and some resting pain in the night, and anything which is like not normal, that is we can take as a symptom of the arthritis, which he was doing previously, like maybe 1 year back he was able to walk 8 kilometers, but now once he started walking, and after 2 or 3 kilometers he get his knee or hip, his shoulder stiff, or maybe some discomfort and pain. So these are the clinically earliest sign of the getting the disease. So these orthopedic joint
can
disease
you please translate as well? Dr. Bohra, 2 minutes. Shashank, can you please translate as well? Dr. Bohra is talking about the diagnostic part in terms of how to start for the French speaking people, doctors.
Yeah, I can take a pause if somebody want to translate. It's okay.
Yes. Shashank, can you please translate? And you can please switch on your cameras.
So
okay, Doctor.
That's why keep your both side open so I can listen from you as well. That I need to stop. Okay.
Okay, sir. I'll translate. Can you go once?
Dr. Bohra, you can start. He'll translate you line by
Okay,
line.
Shashank, Dr. Bohra said that first thing is X-ray. X-ray will say progression of arthritis to the doctor there, let's say Nigeria. And then they have to correlate with clinical symptoms. Like he said, if somebody has difficult doing normal activities like walking, he said if somebody is able to walk 8 kilometers, but when they walk 2 kilometers now and they feel pain, that clinical correlation. Am I correct, Dr. Ishwar?
Ok, docteur Ishwar a expliqué que quand on fait le diagnostic d'une patient, comment on peut faire le radio Première chose, c'est le scanner, c'est le radio, rayon X. Et après, c'est les symptômes qui nous suggèrent qu'est-ce qu'on doit faire avec le patient. S'il ne marche pas bien, s'il marche pour quelque temps, il a mal au genou, il a mal articulaire. Il doit rencontrer le médecin, il doit faire le radio. Et après, docteur va décider c'est lequel suite on doit faire avec le patient. Yes, continue.
So once you have done taken the clinical history, which I said that, you already translate that, and the pain
Yes.
and walking you translated and X-ray. So by taking clinical history and getting X-ray, then you come to know that my patient is having, yes, some startup of the like arthritis. So at that stage, you can tell patient to modify his or her activity, like he should not for stretch himself or herself the way he was doing before, to give time for healing. This stage where you can reverse the early stage of disease.
Ok, oui, maintenant qu'on a fait le radio, on connaît la chose, on connaît la maladie, on connaît c'est quel niveau, c'est touché à quel niveau. Si c'est à premier étage, c'est premier niveau, si la maladie est débutant, on peut faire corriger par notre vie quotidienne, de marcher bien, de faire les choses qu'on doit faire et les choses qu'on ne doit pas faire, comme les exercices, ne pliez pas beaucoup le corps et ne pèse pas les choses. C'est ça qu'on doit faire dans la vie quotidienne. Si notre maladie est avancée, si il exige une intervention, on peut connecter avec Dr. Bohra. Yes, sir.
Yeah. And there are some medicine which gives the healing for cartilage. They are freely available. So either I don't know really what is the available there with a different name. So these are the like glucosamine, chondroitin, and collagen peptides. These are the medicine which with along with some exercises will help for to regain the previous disease state of the all joints.
Il y a des médicaments comme collagène peppermint, pour augmenter le cartilage et même pour l'ose, il y a des médicaments. On ne sait pas on ne sait pas le nom parce qu'en Inde, c'est le nom différent et en Afrique, c'est différent. Mais la même composition, on peut suggérer, on peut écrire des médicaments avec des exercices nécessaires pour les patients pour regagner, pour regagner la santé à la même chose. Yes, sir.
Okay. Then you can see the this is the beginning of that is then, yeah, some patient may not come at this stage. So any patient which is continuing with this pain and so then they will start the limping. So their gait will be started affecting, like they will start walking with the limp. Means they will tilt every time while walking, or one hip is down and one hip is up. So that is known as limping. So once they started limping, that started affecting the other joint of the body, like spine.
Vous connaissez maladie progresse avec les symptômes. Quand les symptômes suggèrent que le patient ne marche pas bien, il ne marche pas tout droit. Quand il marche, il tombe. Quand il marche, il ne marche pas droitement. Il marche il voit que, ok, son pied plié quand il marche. Sa maladie est augmentée. Yes, sir.
Okay. So at this stage, you will find the different X-ray. They will more deform X-ray. So at that stage, they start limping. They have the more poor quality of life day to day. Then they need some intervention. Then that is known as stage 2-3 arthritis. That can happen to the shoulder, hip, and knee equally. I am giving the all overview of the all three major joints which I deal.
OK, c'est le troisième niveau de l'arthritis. OK, c'est le troisième niveau de l'arthritis. Dans ce cas, quand on fait le rayon X, on voit qu'il y a beaucoup de déformités dans l'os, dégénération dans l'os, et on a besoin d'intervention chirurgicale dans ce cas. Yes, sir.
Dr. Ishwar, somebody has a question. Do you want to take it now
Yeah,
or do
please,
you take
please.
it at the
It's
end?
better to having the in between, like, right?
So, one doctor, Orunana Paul Edugbo, he has two questions. First is, what are the commonest indications for knee and hip replacement surgeries?
Yeah. Just a minute. Let me. I'm sharing my screen as well. Is it okay? I can share my
Yeah, yeah.
screen.
Please, sir. Please.
Okay. Just a minute. Huh? I'm little poor about this kind of the technology.
No, no,
I
it's
know
okay.
orthopedic technology.
Your skill is surgeon, no? That's
Sorry. Varun, from where I can do share this screen?
sir, there would be share screen button in the bottom panel.
I'm looking at, but I'm not.
1, 2, 3, 4, 5,
Ready.
6. From the left,
Green
sixth
button.
one.
Comments, notes.
From the left side, there is a mute icon, stop video, security, participants, chat, and share screen, sir. It would have a green icon. Or, sir, you can share it with Dhruva and he can share on the screen.
Right.
Or you can share it with Dhruv on WhatsApp and he can share on your behalf on the screen.
Let me figure out. It will be easy to control me. No?
Yeah.
Just a minute.
Actually, sir, there will be a small control panel on the bottom of your screen.
Yeah.
And the left side, it should be fifth or sixth button. It would be green in color with an arrow. It says share screen.
Let me try. Yeah, so I will keep on doing. Meanwhile, answer for that. What are the indication for the joint? He asked me the joint replacement, right?
No, yeah. So commonest indications for knee and hip replacement.
Yeah, most common indication is the age-related osteoarthritis, stage 3 and plus, means stage 3 and 4, where these are the absolute indication for the joint replacement in both hip and knee. Another most common indication is the rheumatoid arthritis and trauma. Post-traumatic malalignment of the hip or knee can lead to the arthritis.
And sir, here's
Other
Dr. Paul.
indication is very different, like autoimmune arthritis, gout, any like systemic illness, or maybe coagulopathies. And nowadays we see a lot of post-COVID AVN for the hip. Avascular necrosis of hip is another big reason for the hip replacement.
Dr. Ishwar, there's another question from Mr. Dr. Paul. Please kindly share for their understanding, how is AI applicable to orthopedics?
AI is it's a game changer, and maybe in more future, because AI is like kind of imageless, no extra investigation we needed, because an AI it's give a real time information about your patient, and joint alignment and what kind of the rotation you need, what kind of the gap balancing you needed in the arthroplasty. So AI is, I say, if we look at the history, in very beginning there was a patient specific instrumentation. PSI was very common in practice, but there was a limitation because that was only allowing you to the take cut. Then came the that computer navigation. After that came robotic, and now is AI with robot. So AI is basically a 3D alignment of the joint by you see the virtual camera, and a very small laptop, you can do all surgery. It's like better than robot because it need no pre-operative CT scan, MRI of the joint, and no extra articular pin placement. It is a kind of pinless, imageless modern technique for the joint.
Sir, there is another question from another doctor, Dr. Audite. Is
Mhm.
there much preparation before surgery, like replacement, any joint replacement surgery?
Yes. So, any joint replacement, mainly major hip and knee, and even shoulder, we do the screening and optimization of the patient. Screening means any patients having kind of any medical illness, systemic disease like diabetes, uncontrolled hypertension, or maybe coronary artery disease, or any potential source of infection like any existing pneumonia or sometimes skin infection, fungus infection. These kind of things should be ruled out. Another is vital, like hemoglobin should be more than 10, or the whatever parameters in our country different because of the different population, the different level of the hemoglobin and the other things. So accordingly, first we need to screen out the patient for the medical condition like hypertension, diabetes, CAD, any autoimmune or systemic disease, and any source of infection. These five things are measured to screen out. After that, you need a lot of investigation like dopamine stress echo, and if you really want to go for some technology, then we made it a CT scan, MRI, and then you need a good OT staff and clean, sterile and clean OT, and trained staff, and post-operative care. You need a good ICU and good anesthetist and standby cardiologist. If something happen, they should be able to take care of it. And maybe blood bank is desirable because most of cases need a blood transfusion, so we should have a blood bank or maybe some arrangement for blood transfusion. So these are the major things we should keep in mind.
Dr. Ishwar, since you talked about blood transfusion also, so many times we get patients from Jehovah's Witnesses. Is their religious belief not to get transfusion, a blood transfusion of any kind? So we have
Yeah.
had such queries, and at BLK only, Dr. Girdhar has operated on a couple of such patients where blood transfusion is not needed. Is transplant like knee and he joint replacement surgeries possible for such patients who, because of their religious beliefs, cannot accept blood transfusion? Is it possible?
Yes, then in these cases, we have to optimize patient before surgery. Means we if patient is not having adequate hemoglobin level, then we need to give them some hematinics or iron injections and some diet, and we need to wait for a couple of weeks to get the good hemoglobin level. Even after that is not happen, then we have an option of autologous transfusion. Means we can take the patient's blood.
Okay.
Yeah, and that same blood will be transfused. So it is not a transfusion, it is an autologous transfusion. It's the same patient's blood, same, even no cross matching, nothing is needed. Just we have to remove the blood and put in blood bank as a with the temperature control. And once it's if needed, we can give the same blood to the same patient, his own blood.
Thank you, Doctor. So I think you got interrupted with the questions. I think you were about to touch stage 3 and stage 4, which are where.
Yeah, I know, I remember. So that's okay. But after otherwise, doctor also forget what they are supposed to ask. So it's better once things come in the mind immediately. We should discuss.
Okay, we have one more question, sir.
Yeah.
Which type of pre-operative? It's from Dr. Venuste Musoni. Which type of pre-operative templating do you use to achieve accuracy for your joint replacement?
Pre-operative.
Templating, pre-operative template that you might use.
Yeah, that was. Now it's old thing to do the templating. Initially, it was a physical templating. Then came to the digital templating. So still there are software which can give you the accurate size for the your acetabular cup or the femoral stem size, or for knee like femoral and tibial size. But because we are now shifted to the more advanced techniques, so we don't do template. That is the intraoperative or robotic assisted guidance, which give a more accurate size and uh, dimension of the implant.
Okay. Dhruva, are there any other questions, or otherwise Dr. Ishwar will continue with.
No, we have 6 questions, but I think we can continue and we can ask or address them later.
Okay. Dr. Ishwar, there are 6 questions which were
Yeah, please,
given
please,
from the
please.
users. Do we discuss them first, or do we let you
But it's
complete?
better. So I will also have some idea what is going in the mind of the audience.
Okay, okay.
Sure. So let me share my screen once.
Yeah.
Sharing my.
Hi, is my screen visible?
Yes.
Cool. We had first question by Dr. Austrian Victor. His question was, what is the new advancement in total hip replacement? And are there any new alternate treatment to total hip replacements?
What are the
new advancement in total hip replacement? And are there any alternatives to total hip replacement, where rather than total hip replacement, something else would be done?
Okay, you are sharing the. Now I got the. Share. I was looking at the sharing at the no PPT. That's why I'm not getting. You should tell me that. Oh, orthopedic surgeons generally have this brain in the knee. So yeah, what is the new advancement total hip replacement? Are there any new alternate treatment to the total hip replacement? Yes, there is a lot of new advancement which I told, like computer navigation, robotic, and AI, and the technique as well. Approaches. Other advancement is approaches, like initially you look at the doing the method of hip replacement is like posterior approach. These are Varun, you must not be very familiar with this thing, but you can understand that how to enter in the hip. Like majority of surgeons, they enter in the hip by the posterior side. When you feel you are at hip, that is a prominent bone, that is a trochanter. So you enter in the hip for the surgery behind
You
this
see how it feels
trochanter.
when you
But
when you
nowadays,
needed to
there is advancement in
listen
the
maybe to
approach
voice
is
notes
like
or maybe
that.
when you play.
Direct anterior approach. We directly going to the hip by front of the hip,
Voice notes
where we
like
do not cut any kind of the muscle or the
from
tissue.
David.
So that is.
I have one request. See, please, somebody, there is a background noise. Please put yourself on
What
mute.
is this?
We are missing what
Oh.
Dr. is saying.
Why are you participating if you don't want?
Sorry?
Doines, are you asking a question?
I think
Dr. Doines was trying to ask a question.
okay. Dr. Danies, let Dr. Ishwar finish this question, and then you can ask a question. Yeah.
Yeah. So it is the first thing is advancement in the method of doing the surgery.
Okay.
That is how you enter the hip. So there was a lot of muscle cut in the before approaches, like posterior approach and direct lateral approach, where need to make cleavage to enter the hip joint. But nowadays we go through the direct anterior approach, which is known as DAA, direct anterior approach, or some people say it is superior approach, direct superior approach. In this, there is muscle cut, no nerve, violation, and very minimum blood loss, and MIS, minimum invasive technique, MIS. Incision is very less, and even patient can go home after 1 day, or maybe sometime the day care he can do.
Okay. There was another question which was asked real time. Okay, many. So, Dr. Odette Fernando's, what is the risk of infection from this surgery? replacement.
Practically in our setup, risk for infection is 0.
Okay.
But yes, because of the patient factor, surgeon factor, these are two main factors which can give the infection. What is the patient factor? Is like a patient is like immunocompromised, like patient is having some comorbidities, uncontrolled diabetes, or maybe associated like hepatitis B, HIV, or other like viral disease, and still we are need to perform the surgery. Then these kind of the patient heart is high risk of infection. Surgeon factor, if surgeon is not well versed and your OT and operating circumstances is not good and OT culture is not good and there is not adequate medication available and post-op care is not good, then also there is chance of infection. So per se, because practically 0 cannot be word because there is infection. So in our setup, infection rate is less than 0.03.
Oh.
Yeah, yeah,
How impressive.
yeah, yeah.
So I think there is a hand raise from General Dima. Sir, you can unmute yourself and ask the question to Dr. Ishwar directly. General Dima. General Dima is from Ghana.
Hello, good morning.
Good morning.
How's everybody this morning?
Yes, yes, sir.
Please
I joined a bit late.
No problem.
Yes, but I want to find out.
I'm hearing.
Recent nutrition. Yes. I want to find out the recent nutrition care for patient placement.
Can you repeat, Jen?
Because evidence suggests that, yeah. Can you hear me?
Yes,
Yeah,
now.
Can you hear me, please?
Yeah, I'm hearing now.
So I'm saying that, yes, good. What is the recent evidence in terms of nutrition care for patients who are actually having joint replacement? Because you would realize that they would probably be needing, yes, nutrition care. How has joint replacement affect nutrition, or how does nutrition affect joint replacement? Because you would have to, and what is the relation between dietitian or nutritionist and doctors in terms of care for joint replacement?
Yes, Dima, it is really very good question asked by you, because there is a one gut joint axis theory. Gut joint axis theory. Even if somebody is not having the joint replacement, your gut is very important to manage all over body. So this is a recent gut joint axis theory where your gut is not absorbing micronutrients properly, and your any celiac disease, gluten allergy, or any chronic illness like Crohn disease and ulcerative colitis or chronic acid peptic disease APD, all these are linked with the increased chance of the arthritis. That could be like maybe autoimmune arthritis or could be a degenerative arthritis. So chance of increasing arthritis is high. And you talk about the post-operative nutrition. It is very important because any surgery lead to decrease in the general immunity status of patient for 12 weeks to 20 weeks. So at that time, because patient in hypercatabolic state, we need to give them good protein diet to compensate that catabolic state, dissolving protein amount of the body. So in that case, you can give the milk and milk product, protein powder, and some like vegetarian protein, and increase the total calorie so patient get the immunity as soon as possible after surgery.
So there is another question from Dr. Henry Musi.
Please, moderator, I'm just following up on the answers you gave. I think I really appreciate that. And my colleagues who are here should take note, so that at least in our management of some of these cases, we can refer, because more often than not, what we've realized is that doctors would want to manage cases, and then a lot of them don't consider the nutritional factors, you understand? So my point, I'm just adding up, is that we can play that collaborative role, so that when we have set patient to have joint replacement, irrespective of wherever or which part of the body, we can consider the hypercatabolic state of the patient and then refer for the dietitians or nutrition.
Great. Great. Dr. Dima, General Dima, you are on mute again. Did you finish?
Yes, I'm done. Thank you.
Okay. So there was another question from another audience member, Dr. Ishwar. And the
Please tell
question
me.
is from Dr. Henry Musira. He's from Uganda. What is the definitive management for recurrent shoulder joint dislocation?
Yeah, for recurrent shoulder dislocation, there are the two type of surgery. One is like arthroscopy surgery, one is the open surgery. So majorly, most of the patient without any too much dislocation, number of dislocation, like some patient is having dislocation more than 10 times, then probably open surgery is better. Otherwise, arthroscopic Bankart repair plus remplissage procedure. Arthroscopic Bankart repair and remplissage procedure is the gold standard for the recurrent dislocation of shoulder. Many patients having, because of the too much dislocation, maybe frequent dislocated, they have bone defect. Bone defect can be in both sides, in socket side and the head side. So if only socket side, then you can do the bony augmentation of the glenoid socket. And if there is a more than 30% defect or Hill-Sachs lesion on the femoral side, humeral side, then sometimes you need to grafting. Otherwise, by simply putting the teres minor muscle at the defect, you will be get away with the problem. Same procedure, which is open procedure, that is known as a letarget operation. Now we are starting doing arthroscopically. That is known as arthroscopic letarget procedure. It takes little more time, but it is complete arthroscopically. So recovery is fast and there is no incision. So it's a difficult procedure. But now the same procedure which was being open before that, we are shifted to doing the arthroscopically. So these are the major procedure for the recurrent dislocation. And simultaneously, any other pathology like rotator cuff or biceps that get addressed at the same time.
Okay. So there is another question, and it is from Dr. Odette Fernando Sitole. What he wants to, there an estimate age to do the surgery. For example, the patient can ask if I'm too young or too old for knee replacement. So this is what he anticipates the patient. If he suggests knee replacement, the patient would ask him, am I too young or am I too old for knee replacement? Is there something?
Absolutely. There is the criteria for the knee replacement. There is age criteria, because you look at the durability or survival of the implant, it is not too great. Initially, it was only 10 years. Now we are in the third generation of the knee replacement, where the implant longevity is high. That is almost 30 years approximately. So cutoff age for knee replacement, due to some reason, generally younger patient need a knee replacement for traumatic arthritis, where some accident happened and that cartilage is completely torn, which cannot be reconstructed. Then we need a knee replacement or maybe hip replacement, where you cannot give the congruent joint and your cartilage is completely damaged. Then we need a joint replacement in form of the knee or hip, whatever. So there is, after for hip replacement, you can do after 18 years of the age, because like congenital dislocation of the hip or the persist disease or other younger age hip problem are more frequent than the knee. So cutoff age for the hip replacement is 80 years when the bone growth is completed. So after that, any time you can do the hip replacement. Even sometimes we do the early hip replacement in special cases like sickle cell disease or coagulopathies, where hemophilic patients, they have a very bad joint and painful joint. So even very younger patient, we can do hip replacement. For knee, same, like hemophilic sickle cell disease patient or any traumatic, there is no age criteria even after 20 years where the patient is not able to walk or having severe difficulty. We can go for the even knee replacement, because nowadays implant lasts more than 30 years. So suppose patient is 20 years of age, you can revise the knee or hip at the age of 50. So that's not bad deal. At least patient is walking and productive and pain free. And for old age, it is totally dependent on the medical condition of the patient. We have done the hip replacement in 104 age patient.
Oh,
104.
that is amazing, sir. So from
Yes.
India or
Yes.
from some other country?
So age is a number only. It is all the physiological age which is important, not the statistical, numerical age. So that is the physiological age which is important.
Okay. Sir, we have more questions left from which were received before the talk, and you have your presentation also left. What should we do now?
No, this presentation is just to have the idea in which kind of X-ray you think that they should do the knee replacement, hip replacement like this is like.
That will be useful for them, sir.
Yeah. So you can look at the X-ray picture that if you see X-ray like this, there is no option other than the surgery. You need to counsel the patient that yes, you are wasting time. You need to do something, or either you leave it with it or do get the surgery. So these kind
Shashank,
of
can you please
X-ray in the
translate
OPD we
also?
see.
Shashank, can you please translate? I think this is important for all doctors, that if they see this kind of an X-ray, these are the next steps.
Yeah. Bone defect,
Shashank?
angular deformity, hypoplasia, necrosis, and
Oh
other
oui,
previous surgeries.
sorry, I was on mute. Ok. Maintenant, devant nous, il y a une image qui nous explique le dépistage pour la maladie, pour l'arthrose, pour l'arthrose de genou, qu'on doit remplacer les genoux. Maintenant, docteur nous explique image par image qu'est-ce qu'on doit faire avec rayon X. Yes, doctor.
Can you repeat again? I really sorry. Can you speak little loudly?
No, sir, he
Oui,
was just
moi.
translating what you said to
Okay,
the
I
okay.
have translated.
Okay, all right. I think they are asking me something.
Okay, I think Dhruv, you should ask those questions because it's already almost 5, and I don't know how long the audience would want to stay.
That's why asking. My interaction is better than to learn, because everything available on Google nowadays. So,
Okay.
yeah.
So Dhruv, can you ask the questions?
This is a very young patient. You see, this is the defect on the medial side. Even this patient need some support and the knee replacement. Yeah.
So doctor, there's a question by Dr. Brenard. He want to understand if there's a possibility where we can arrange clubfoot virus for a 3-month-old child.
Clubfoot in virus for 3 years?
3 months old child.
Yeah. Nowadays, clubfoot treatment start from day 1. Because as soon as possible, because when you do the level 2 ultrasound, you are able to diagnose the clubfoot. You understand? Before birth, you can diagnose the clubfoot. So your patient and you should be alert that your pediatrician or maybe gynec who is looking after the gynec should aware that I have to inform my ortho surgeon that this baby is going to have a clubfoot. So initially on day 1 or 2, because skin is very fragile on the newborn baby. So once you put a plaster, it's difficult. So maybe after 2-3 days, you can start putting the manipulation and the serial casting.
Okay.
Got
You
it. So I
understand?
think age is not a number. It could be done with
Yeah.
even a 1-day-old child.
Yes, yes.
Got it. So we have another question by Dr. Rabiu. He has asked or he wanted to know the post-operative prognosis of spinal cord injury.
See,
Mm,
spinal cord injury is a big and debatable topic. If there is a complete spinal cord transection, nothing is working as of now. No stem cell, nothing else, and nothing can is regenerating spinal cord. So future is not good when patient have a complete transection of spinal cord. If there is a partial injury and some roots and some nerves are available and they are viable, patient can have some kind of the movement with the wheelchair or braces or otherwise patient will be completely paraplegic. There are other devices like day-to-day life assistant devices like these are computer robotic chair and which stimulate the your calf muscles and thigh muscles and the bladder training, because these patients are remain completely paralyzed, so there is a incontinence of urine and the stool. In that case they need training for this day-to-day activity. So these are the very specialized program and specialized center which train the patient for to how to live with this kind of injuries. But prognosis is not good once the patient has a spinal cord injury.
Understood. So I'll move on to the next question. Next question is by Dr. Elboraj. He's asking, is the electromyography and the nerve conditioning study a diagnostic procedure required during orthopedic treatment of people?
Which one?
Uh, let me pose the question in chat. Electromyography and nerve conditioning study, are they required
Electromyography
for
in NCV.
diagnostic?
Okay. During?
So, diagnostic study during orthopedic treatment of people, is it required or is it a necessity?
Yeah, depend on the patient with nerve injury. Then we need a NCV and EMG. That is short form is a nerve conduction and EMG, electromyography. Okay. So that is a
Right.
vital role by the neurosurgeon and neurologist and orthopedic surgeon, plastic surgeon. So they all this is basically diagnostic tool. If you want to see the muscle power and nerve strength or the what are the nerve velocities there or nerve conduction is there. Depend on the circumstances, like you have a fracture humerus and your wrist is dropping, then you need to diagnose that this is a complete adult nerve injury or which are the other ulnar nerve, medial nerve is involved in this kind of. So then we need a EMG and the uh, NCV.
Dhruv, move to next question, please.
Understood. The next question is from Dr. Ebraha. He wanted to understand, how do we proceed in local setup despite limited resources? Where even the diagnostic and he's not clear. I think then he should reach out to you through Jivo. And I think that answer is clear. We just
No.
communicating
Let
it.
let Dr. Ishwar answer.
What is the
Right.
question? How to set up the?
How should a doctor proceed in their local setup when the procedure is very complicated and they have limited resources?
I think it will be unfair to the patient. It will be unfair to the patient if you know and first hand that there is a problem to perform or complete this procedure with a good result. We should not do. Even some procedure we here at the highest level of tertiary care, we also don't do, because there are two reasons: either you have a limited resources or you are sure about the outcome. If outcome is not good, you should counsel the patient. You have a meeting with the patient, his family and attendant. This should be counseled, and then if patient is willing that yes, I know and I'm aware of everything, then you can proceed for the procedure. But you should be aware that what best you can deliver, you should tell them, and you should tell them that these are the limitations which I can't do, but that yes, by this getting this procedure you will get this much of the benefit. That should be counseled.
Dhruv, next.
Fair. So we have last question informed from Dr. Atlanta. So this question has multiple parts. The first part of the question is, how long can the hip or knee replacement stay at the patient?
How
Or
much?
what is the life of knee and hip replacement?
I told you this is more than 30 years now.
Right. Then he wanted to understand what is the prognosis of the replacement. And he wanted to understand, is it the permanent replacement or patient need to re-replace at a certain age or stage? I think he's asking the same thing, that after 30 years,
Yeah.
or you could answer or clarify.
Yeah, I mean, prognosis is very good nowadays because patient can do everything. Even nowadays, we are doing hip replacement with the high flexion, so they can, do the prayer. They can read the namaz, and even with knee, after 3 months, many patients now started reading our prayer by kneeling down position and squatting.
Got it. And the same doctor also wants to understand a directional pricing for an average citizen so that he could understand what is that average pricing in India for knee and hip
Pricing.
replacement. Yes.
Yeah, it is Varun, and you can give them better answer. But yeah, look at the large of the orthopedic surgery. So they are vary between $5,000 to $10,000. So
Got it.
how much serious is the surgery? Yeah.
Yeah.
Understood.
So, Dhruv, you should answer him. It depends on the surgery. And actually, this answer will come from BLK commercial team.
Yeah. This
Right.
That decides, I am going to do this procedure, A, B, C, D, these steps, these are needed for the patient, and the commercial team decides. Even we will not have that answer, will vary from
Right.
case to case.
So once
Pankaj,
we study the case, and then we can decide the price. And we are always very flexible to help these interested patients. So we are
but
very.
at BLK, at least for some cases, like they have packages about
Yeah.
knee replacement, joint, hip replacement, bilateral, unilateral. Pankaj will
These are
give.
a very competitive and very affordable price too if compared with the other countries. So we are giving the very best quality treatment with a very reasonable price.
And Dhruv, to this question, whoever asked this, just get those information from BLK team and they have ready. Just share it with them so that they are also
Yeah.
aware. If the patient asks, they have the answer ready.
Yeah.
For hip replacement and for knee replacement, unless there is some complication in the patient, those would always outside. But for mostly, BLK has created packages so that the patient knows even before they travel, what is it going to cost.
Fair. And this last part of the question left, which is there any alternative to replacement? I'm not sure if he's asking generically or for a
Yeah,
specific
alternative
case.
is definitely if somebody is like afraid or they don't want to take the replacement, then there are a lot of braces available. They can use cane in hand, some lifestyle modification, some medicine like analgesics and other things, and like supplement and to enhance the strength of the bone, calcium, vitamin D, glucosamine, and collagen peptides, and some alternative therapies they can try.
Yeah. Dr. Ishwar, if we give the audience a chance, like, do you have time to answer one or two questions more, maybe?
Yeah, please, because then I rush to the theater. Maybe
Okay.
5 minutes more, then we can conclude the meeting.
Okay, so my request is if anybody has any question, now now is the time to ask Dr. Ishwar. Even if you have questions later on after
Yeah,
this
you can mail
talk,
me or WhatsApp me, sir.
correct. So you can share those questions and Dr. Ishwar. But there's no time like now. He's here for
I think there is one
4
question in chat as well from Dr. Henry. He has asked, what is the definitive management for recurrent shoulder joint
So he
dislocation?
answered this. He already answered this. That was answered.
Got it.
And sir, there is a request from one of the audience that is it possible to send them a PDF of your presentation?
Yeah, we'll definitely. Yeah.
Okay.
Yeah. So thank you very much for everyone to sparing time, and I hope that we have some good, useful discussion. And I'm sure that it is very short time to explain such a huge topics. But Varun and Dhruv is there, so any information you want regarding like any orthopedic or neurosurgery or any spine procedure, I'm always available, and you can send me. And I request everyone to any orthopedic like joint problem or bone problem, musculoskeletal problem, or even bone cancer, we have a state of art center in one roof. We have like my a deformity surgeon, I am my foot and ankle surgeon, I am my onco surgeon. So that's why we do very subspecialty work as well. So I request everyone, any ortho patient, so you can send to one point where we can give a one time and one stop solution.
So,
Ok, maintenant, docteur nous a, oui, qu'est-ce que docteur nous a dit? Ici, on a tous les domaines sur dans le toit. Ok, on a tous les domaines comme le oncochirurgien, on a l'orthopédique qui est spécialisé au l'épaule, genou, hanche, tous les arthroses. On peut traiter tous les arthroses et tous les domaines de corps. S'il y a un cas, on peut contacter Jivo, on peut contacter docteur, ok? Faites-nous signe si vous avez le cas comme ça, concernant l'arthrose, articulation, on va vous tout donner concernant votre maladie, que vous pouvez rentrer avec votre traitement confortable. Sereinement. Merci.
okay, I have one final request to Dr. Ishwar sir, because if before you sign off, just give the audience the comfort that actual surgery, actual problem, it comes later. But if they get stuck anywhere when they have an ortho patient, they should feel free to get in touch with you.
Absolutely, this I told you. So you guys, share my WhatsApp number, or maybe you can have a direct connection. They should be have some, connect
Yeah.
with you. So immediately you can connect me. Even theater, we have a facility up to telecasting. If they have a good network there, so they can do connect with me. But it need a little time. I should not be in between the theater, right?
No,
So
sir.
maybe like an hour before, once they are having some emergency, then you should try. So
No, sir, all of them
if
have
not, I
a.
am available. My team can be solve the problem immediately.
Sure. Dr. Ishwar, just to give you comfort, all of the doctors who are on the Jivo platform, they have a relationship manager who is there to solve any problem for them.
Yeah.
They want to encourage, even if it seems like a very innocent question to them, they should ask. And the team will
Absolutely,
take
they
it
should.
and will.
Learning have no like ego or anything hesitation.
Yeah, I think
Every
actually
question is important.
we have received one more question. What is the experience of joint replacement in children like?
Children. Yeah, I told you, because somebody asked about the age criteria for the joint replacement. This is very wise question. Sometimes we do the replacement the children, as I told you, like if like they have a hip pathology like skiffy or avian or maybe persist disease or maybe traumatic hip fracture, even children, or septic arthritis, Tom Smith arthritis, where we have to do joint replacement in the children as well, because in that joint there is no growth potential. So this bone will not grow. So at least that child can have a painless life. And opposite side of the joint, you can do the hemiepiphysiodesis and arrest the growth. So there will be no limb length discrepancy. You understand?
Okay.
Yeah. And even same with the knee. The knee is like get completely worn out by the like hemophilia and the sickle cell disease, or maybe some viral arthropathy or some kind of the other infection or the injuries. So sometimes it is compulsion to do the replacement in the children as well, and they do very well. Yeah.
Okay. Thank you, Dr. Sir, Dr. Ishwar, and I'm sure of another question, sir, but if you can take it. What is your preferred mode of anesthesia? Do you practice upper extremity? It's
Upper
from Dr.
extremities,
What is
general
your preferred
anesthesia
mode of
plus block.
anesthesia, and do you practice upper extremity? This is the question.
Yeah. General anesthesia and the block. General anesthesia and nerve block.
Okay.
Yeah.
Okay.
Okay.
So thank you, and Dr. Samuel, thanks you a lot. Dr. Dilyet, and thank you, Dr. Ishwar. Hopefully,
Thank you.
you
So
can find
Varun,
time to
I am always available. Any help for all the platform
Yeah.
doctors, we can connect anytime. And my request to everyone, any ortho problem, just you can without any hesitation share with us and we'll find a solution.
And I just want to give them comfort that everything begins with a dialogue.
Yeah,
Jivo
yeah.
is bringing them on a dialogue platform with specialists like you.
Yeah,
But from their
it's
side,
my
this will
privilege.
start,
Yeah,
right?
yeah, it's my privilege.
So it is like doctors should run healthcare, not agents.
Yeah. Thank you.
Yes, sir.
Have a
And
nice day. Bye bye. Take care. Bye bye. Bye.